So thank you all again for joining us today for our third webinar of the Improving Childhood Obesity Care, a Grow Healthy series. My name is Dr. Stephanie Waldrop, and I'm an assistant professor of clinical science here at Pennington Biomedical. I will be moderating today's session and look forward to engaging with all of you. Next slide. So what is Grow Healthy? Grow Healthy is an evidence-based public service initiative grounded in decades of childhood obesity prevention and treatment research from Pennington Biomedical Research Center. Pennington Biomedical is a world-renowned research center that promotes metabolic health and eliminating metabolic disease through scientific discoveries. Visit our website at growhealthy.org for more information. Next slide, please. Recordings from our first two webinars of this series are now available on our website. In March, Pennington Biomedical's very own Dr. Amanda Stiano with Dr. Alyssa Button and Ms. Angèle Ulmer presented on intensive health behavior and lifestyle treatments for pediatric obesity, motivational interviewing, and behavior change strategies. And in May, Dr. Katie Queen guided us through a must-do checklist for a pediatric obesity visit. CME credit is only available for live sessions, including this one. Grow Healthy has recently launched a childhood obesity prevention, evaluation, and treatment toolkit for providers that is available online through our provider hub. This toolkit is a refresher or introduction to the AAP's clinical practice guidelines. We will place a link in the chat to download it. Grow Healthy is also excited to announce the Be the Reason Kids Grow Healthy Childhood Obesity Conference. Please join us on October 3rd with an optional pre-conference workshop on October 2nd. The conference will be held in Pennington Biomedical's Conference Center. Registration is live with early bird pricing ending on July 31st. The link to register will be entered in the chat. Next slide. And further for your information, here is an accreditation and credit statement from the Louisiana AAP, which we have coordinated with to offer today's CME credit for free. Now, I would like to introduce everyone to today's presenter, Dr. Zubaidah Nor Hanipah, MD, MS. Dr. Zubaidah Nor Hanipah is an associate professor in research in the Clinical Metabolic Surgery Laboratory at Pennington Biomedical. Dr. Nor Hanipah's research interests encompass a comprehensive study of metabolic and bariatric surgery outcomes with primary emphasis on obesity, metabolic disorders, and metabolic syndrome. She is particularly focused on exploring how metabolic and bariatric surgical procedures can effectively mitigate the complications associated with obesity and metabolic syndromes, leading to improved management and potential remission of type 2 diabetes and non-alcoholic fatty liver disease. And now I will pass over control to begin the presentation.
Thank you, Stephanie, for the kind introduction. And thanks, everyone, for joining our Grow Healthy webinar series. Today, I'll be presenting on a topic titled Metabolic and Bariatric Surgery in Adolescents, and an overview and its efficacy. This is my outline of my presentation today. So 20% of U.S. children and adolescents aged 2 to 19 years have obesity. 21% of adolescents aged 12 to 19 years have obesity, which is approximately 1 in 5 are affected with this disease. 6% out of them have severe obesity. This has caused a pretty much high health burden due to increased risk of type 2 diabetes, sleep apnea, metabolic dysfunction-associated fatty liver disease, and cardiovascular disease. More drastically, it has caused high economic burden to the country, which is about 14.1 billion in annual medical costs for managing childhood obesity. There are many challenges in managing severe obesity in adolescents. Non-surgical intervention often achieves less than 10% of sustainable weight loss, which highlights there's a need for more effective strategies in managing severe obesity in this age group. A significant portion, about 80% of adolescents with obesity, will continue to be obese in adulthood, and this increases the long-term health risk in them. They also suffer from high rates of depression, anxiety, poor self-esteem, which affects their overall well-being. The existing comorbidities such as type 2 diabetes and cardiovascular disease frequently worsen over time without effective intervention in this cohort. Childhood obesity is defined as by a body mass index at or above 95 percentile for their age and sex. There are various obesity treatment options, and it all depends on the severity of obesity. Lifestyle modification, which includes diet and physical activity, contributes about 7% of clinical significant weight loss in 2 years. Pharmacotherapy plays a major role at this era with higher percentage of weight loss with the newer drugs. Orlistat and metformin gives a modest weight loss. Liraglutide gives about 7% of total weight loss about 1 year, and newer options such as semaglutide and tirzepatide gives a weight loss about 10 to 15%. To the other extreme, surgery treats much more severe obesity in adult population, such as sleeve gastrectomy or Roux-en-Y gastric bypass. The total weight loss ranges from 21 to 29% depending on the procedure at 5 years outcome. Bariatric surgery in adolescents is actually recognized as a safe and effective treatment for severe obesity. It has been endorsed by major medical organizations like the American Academy of Pediatricians in 2019, and a year prior to that was the American Society of Metabolic and Bariatric Surgery, ASMBS. Its safety profile is comparable to minor surgical procedures such as cholecystectomy. The most common procedures are sleeve gastrectomy and Roux-en-Y gastric bypass. A comprehensive multidisciplinary care team approach, which includes surgeons, pediatricians, clinicians, dietitians, clinical psychologists, and other specialists, will provide a holistic treatment care in childhood obesity. Patient selection should adhere strictly to the ASMBS or APP guidelines to ensure appropriate candidate receive the correct treatment. The key mechanism of bariatric surgery changes happens in the brain, stomach, pancreas, small bowel, particularly ileum and colon. There's alteration of food choice and intake and reward of food pathway. Stomach alteration has caused vagal nerve signaling and reduced gastric emptying, and also has reduced satiety by cutting down gastrin secretion. Pancreas enhances insulin release, which improves glucose regulation. And mainly in the ileum, we can have increased hormone secretion such as GLP-1 and PYY peptide. And this also alters the bile metabolism, which contribute to metabolic improvement. Gut microbiome poses a composite changes which influence the metabolism after bariatric surgery. According to the ASMBS in 2023 census, sleeve gastrectomy and gastric bypass are predominantly bariatric procedure performed, which is 59% and 23% respectively. However, in adolescent, sleeve gastrectomy predominates by 95% due to preference from a Roux-en-Y gastric bypass over the past 5 years due to comparable outcome with a fewer complications rate. This table, I'm going to share you a bit on the risk to benefit comparison between sleeve and Roux-en-Y gastric bypass. In sleeve, we remove 80% of the stomach. We leave sleeve of the stomach in the patient. As for the gastric bypass, we create a small gastric pouch and we bypass 1/3 of the small bowel to the stomach, and therefore it gives a malabsorptive component to the procedure. In terms of weight loss, Roux-en-Y gastric bypass has superior weight loss, which is about 30 to 35%. And due to that, it also has a higher resolution rate for type 2 diabetes and gastroesophageal reflux disease. Due to the higher malabsorptive procedure, it has a higher nutritional risk, which is more common in iron, B12, calcium, folate, and fat-soluble vitamins. Bypass has a higher surgical risk as compared to sleeve because of the complexity of the surgery with manipulating the small bowel. Therefore, the risk of internal hernia and dumping syndrome is higher as compared to sleeve gastrectomy. In terms of reversibility of the procedure, Gastric bypass is reversible, but it's a very complex procedure as compared to sleeve is irreversible. Due to high risk of nutritional deficiency and surgical risk, the follow-up in gastric bypass patients are more intensive and therefore supplementation are essential and compulsory as compared to sleeve gastrectomy. For those reasons, sleeve gastrectomy has been more commonly performed bariatric procedure in the teenage group. Looking at the efficacy of bariatric surgery in adolescents, I'm going to share three evidence-based landmark studies on adolescent bariatric surgery on the results of 5 years and more. The first one is Teens Lab, which is Teens Longitudinal Assessment of Bariatric Surgery. The second one is the FABS 5 Plus follow-up of adolescent bariatric surgery at 5 plus year, and AMOS, which is a Swedish adolescent morbid obesity surgery trial. AMOS is actually a non-randomized longitudinal prospective study looking at 81 adolescent surgery patients, 80 adolescent non-surgical control, and 81 adult surgery control. And the mean age range is about 13 to 18 and with mean BMI of 46. Its follow-up period is 5 years, and they are doing the ongoing 10 years data that's still pending. The FABS is another non-randomized study looking at 58 and 74 patients. The mean age is ranging from 30 to 21, and the BMI range is about 60. This is about a follow-up period of 5 to 12 years. Teen Labs is a non-randomized clinical trial looking at 161 adolescent surgical patients and 296 adult surgical patients. The age range is about 13 to 19, and the mean BMI is 54. So they have published the 3 years and 5 years data, and they are going to publish, still working on the 10 years data that yet to be published. So long-term follow-up in terms of weight loss. In these 3 papers shows that there's a consistently and sustainable weight loss with significant resolution of comorbidities. The change in BMI ranging from 26 to 29%. In terms of remission of type 2 diabetes, it ranges from 86 to 100%. Hypertension resolution ranges from 68 to 92%, and for dyslipidemia, it ranges from 64 to 83%. So therefore, long-term follow-up in a specialized care are essential for good outcome in adolescent population. This is a study that was published in 2021 looking at the BMI change comparing the Teen Labs group and the AMOS studies. This shows a comparable BMI reduction trajectory between the adolescent and adult population, which shows improvement pattern which is sustainable over the 5 years. If you can see at 1 year, both AMOS and Teen Labs has the BMI reduction about at 1 year is about 15 following sleeve and 16.6 at after gastric bypass. And the long-term data on the Roux-en-Y gastric bypass at 5 years, the maintenance of BMI change is about 13. This table summarizes the cardiometabolic outcome following adolescent metabolic surgery in these 3 landmark papers. I'm going to focus mainly at the elevated liver enzyme because I have mentioned about the type 2 diabetes, dyslipidemia, and hypertension earlier. So if you look at the elevated liver enzyme, at the baseline, 31% of them had elevated liver enzyme. But at the end of maximal follow-up, 92% of them had resolution of the liver enzymes. Same goes to abnormal kidney function. 70% of them had abnormal kidney function at baseline, but there was 86% of resolution at the maximum follow-up rate. Let's dive into the Teen Lab study, which is look at the weight loss changes after gastric bypass over 5 years period. There was no significant difference in percentage of weight changes between adolescent and adult cohort. We can see both cohorts has good weight loss at 1 year, and the weight loss maintained over 5 years period, which is about 26% for the adolescent and 29% for the adult cohort at 5 years. After surgery, adolescent was significantly looks like more likely to have higher remission rate of type 2 diabetes as compared to adult, which is about 86% in adolescent cohort and about 53% in an adult cohort at 5 years. So in conclusion, remission of type 2 diabetes was higher in adolescent cohort as compared to adult cohort. We can see the same pattern in the remission of hypertension. Adolescent cohort has much higher remission rate as compared to adult. And at 5 years, the remission rate for adolescent was 68% as compared to adult, which is 41%. This is significant. So in conclusion from teens lab study, adolescent achieved similar magnitude of weight loss as compared to adult at 5 years follow-up. However, adolescent has higher remission rate for type 2 diabetes and hypertension. There are more papers that was published on the remission of complication of hypertension, complication of obesity after sleeve and gastric bypass in pediatric population. As you can see, in type 2 diabetes, prediabetes, dyslipidemia, even in hypertension. I'm going to share more about sleep apnea. So if you can see sleep apnea, the resolution rate after gastric bypass or sleep ranging from 60 to 100%, and elevated transaminase, we can see it's actually a resolution rate about 70 to 90% after bariatric surgery. This is an abstract that was published in Circulation in 2018, looking at the 30-year risk of cardiovascular disease in adolescents with severe obesity before and after bariatric surgery. 215 adolescents from teens lab was enrolled, and the mean age was 17 years and the mean BMI of 53. They've used the Framingham 30-year cardiovascular event risk score. The cardiovascular event that was included was coronary death, myocardial infarction, stroke, coronary insufficient, angina, TIA, intermittent claudication, and congestive heart failure. The average cardiovascular risk at preoperative was 7.9. It dropped significantly to 4 at 1 year and is somehow maintained until 5 years with 4.8. This shows that following bariatric surgery, the risk of heart endpoint for cardiovascular risk is tremendously reduced up to 5 years following surgery. So in summary, in terms of clinical efficacy, bariatric surgery gives about 28 mean BMI reduction, slightly lower in sleeve gastrectomy group as compared to Roux-en-Y gastric bypass. Type 2 diabetic remission about 78 to 100%. Hypertension resolution ranges from 60 to 100%, and dyslipidemia improvement ranges from 70 to 90%. How safe is bariatric surgery in adolescents? So I'm going to share evidence-based study looking at the morbidity, mortality outcomes, and also long-term nutritional deficiency after bariatric surgery. This is a paper published in Anal Surgery in 2022, looking at the MBS acute database from 2015 to 2021, specifically looking at the 30-day complication of bariatric surgery, comparing adolescent versus adult. We can share the table here. The mortality rate are similar in both cohort, and the 30-day complication in terms of reoperation, bleeding, sepsis, ICU admission, hospital readmission, pulmonary embolism, infection, pneumonia were not significant. The only significant one was the operative length, which is slightly lower as compared to the adult. Another paper that was published comparing preteen, which is age 13 and below, and teen group 13 and above, looking at the similar database, MBS acute from 2016 to 2021. It was predominantly female, and the mean BMI for both groups was 47. We can see here the teen group has a complication rate of 0.5%, readmission rate was 2.9, reoperation was 0.8, and a mortality rate of 0.01. As compared to preteen group, all the complication, morbidity and mortality rate was 0. This is a safety profile looking at mortality and reoperation rate from the teen labs study. So 5-year mortality rate was 1.9%. There were 3 mortality. The first one is a sepsis in type 1 diabetes with hypoglycemia, died post-op 3 years. And there were two overdose adolescents who died at 4 years post-surgery. The reoperation rate was 20%. 46 intra-abdominal procedure and in a 32 adolescent, and 2/3 of the procedure were cholecystectomy. And there was no difference between the cholecystectomy rate between the adult and adolescent in this study. Prevalence of subnormal micronutrient level in adolescent post-bariatric surgery is high. 72% of patients in MO study has some degree of nutritional deficiency after gastric bypass. The subabnormal level is also reported in FAB 5+ and teen lab studies at 5 and 3 years. If you can see here, most of them have low ferritin and iron level, which ranges from 34 to 70%, and majority of almost 2/3 of them have anemia. And the other very drastic deficiency was vitamin D, which ranges from 30 to 50%, and low vitamin B ranging from 8 to 20%. So in conclusion, micronutrient supplement is essential and recommended. However, adherence is very challenging in this adolescent group, and therefore they require a closer follow-up and a tailored regime. This is a prospective study looking at adolescents who had Roux-en-Y gastric bypass, 161 of them, and vertical sleeve gastrectomy, 67, were enrolled at 5 tertiary care centers from March 2007 to 2012. And they were looking at measuring the serum level of ferritin, red blood cell, folate, vitamin A, vitamin B1, B12, and parathyroid hormone at baseline and annually for 5 years. If you can see that gastric bypass has higher nutritional deficiency as compared to sleeve gastrectomy. And at 5 years, Roux-en-Y gastric bypass had 59% of 2 or more nutritional deficiency as compared to sleeve, which is half, almost half, 27%. So nutritional deficiency in preoperative period in the adolescent ranges are quite high, it's about 30 to 50%. However, only 50% of adolescents adhere to vitamin supplement at 5 years follow-up period. Therefore, preoperative optimization is essential to identify and correct micronutrient deficiency way before the surgery. And we need to have a post-operative strategy in implementing intensive monitoring and education to support adherence and to prevent deficiency in this cohort. There are 6 predictors of nutritional deficiency that was published in 2020. One of it is procedure, which is Roux-en-Y gastric bypass. Female has a higher risk of nutritional deficiency, especially iron deficiency. Weight regain. Ethnicity, African American has higher nutritional deficiency, mainly vitamin A, D, and parathyroid. Pregnancy is one of it, and those who are not taking any supplementation has a high risk of nutritional deficiency after surgery. In terms of bone health and fracture risk, these data are mainly on adult studies. So mechanism on fracture risk is basically on mechanical underloading, decrease in vitamin D and calcium level, and altered leptin signaling. Bone mineral density decreases by 9% within 2 years post-surgery. the fracture risk increases by 1 to 2 times after surgery. Roux-en-Y gastric bypass has higher risk as compared to sleeve-in fracture, and most common fracture site is the hip bone. Looking at quality of life and mental health. In general, quality of life improves physical functioning, reduce bodily pain, and improve self-esteem of patients after surgery. Those patients who has mental health problem, they persistent and they had poor mental health preoperatively is a strong predictor of having a postoperative mental issues. There's increased risk of alcohol use disorder and suicidal rates in post-surgical patients with a hazard ratio of 2.8. So in summary, pediatric bariatric surgery has shown significant and sustainable weight loss compared to the adult outcome with minimal long-term weight regain. It shows higher rates of diabetic and hypertensive remission and improved cardiovascular risk factors. It has favorable comorbidities resolution in dyslipidemia and sleep apnea. Bariatric surgery has acceptable safety profile with low mortality and reoperation rate, especially when we select the patient carefully. I'm going to share some of the clinical guidelines and consensus that has been published on the pediatric bariatric surgery guide. So one of it is the ASMBS, which is the first to publish in 2018, and then followed by the American Academy of Pediatricians published the Pediatric Metabolic and Bariatric Surgery Evidence, Barrier, and Best Practices. So the eligible criteria for bariatric surgery in adolescents are those who have class 2 obesity with a BMI 35 or more, or 120% of 95th percentile for age and sex, and these patients must have clinically significant disease which includes sleep apnea, type 2 diabetes, intracranial hypertension, MASH, Long's disease, sleep capital femoral epistaxis, GERD, and hypertension. For patient who has class 3 obesity with a BMI 40 or more, of 140% of the 95th percentile for age and sex, does not require to have any comorbidities. We can notice that there's no lower age limit for children to undergo bariatric surgery. There are few contraindications for surgery. One of it is medically corrected cause for obesity such as hypothalamic tumor or hypothyroidism, substance use disorder within 1 year, a patient who has a medical, psychiatric, psychosocial, or cognitive condition that prevents adherence to post-operative care. So these patients would need a psychological clearance prior to surgery. And those female patient who has a current or planned pregnancy within 12 to 18 months of the procedure. ASMBS published an additional recommendation in 2018, which is prior weight loss attempts, tenure stage, and bone age should not be a barrier to surgery. Vitamin levels should be monitored before and after surgery. We have to maximize the adherence of long-term vitamin supplements. Multidisciplinary team prior to surgery and post-operative care is essential. We have to follow the MBS equipped guidance in terms of bariatric surgery selection and criteria. And we have to have a transitional plan in place for adolescents who transition to an adult metabolic surgery program. I would like to share a case study of a patient's journey with severe obesity that came to Metamor Clinic. So in Metamor, we have a comprehensive bariatric surgery program for pediatric patients with severe obesity and metabolic disorders. We do a thorough preoperative evaluation which involves multidisciplinary team, and we conduct psychological, nutritional, and medical assessment. And family involvement and engagement is very important in every clinic visit with these patients. I'm sharing a case of a 12-year-old male who presented to our clinic. He was referred from a pediatric obesity specialist for severe obesity, who was under her care for the past 1.5 years. His BMI then was 61. He weighed about 334 pounds. He has been on lifelong severe obesity despite multiple interventions. He was homeschooled due to weight-related stigma. He has prediabetes and insulin resistance. He was started on metformin. He has obstructive sleep apnea. He requiring CPAP daily. He has hypertriglyceridemia and lung disease affecting his mobility, who's under orthopedic care. He has been participated in weight loss programs and plan, and there was very minimal success. For example, low-calorie diet, high-protein diet, physical supervised diet, medications such as metformin, liraglutide, and semaglutide. After a comprehensive evaluation and approval from all the multidisciplinary team, he finally was planned for laparoscopic sleeve gastrectomy. This is his picture on his surgical day. After he got approval from the team and he has clearance from the insurance, he finally had laparoscopic sleeve gastrectomy in December 2022 uneventfully. This is picture with his mom. This is his during his post-operative follow-up care 6 months after surgery with Dr. Philip Shower at Metabolic Clinic. He had very successful weight reduction trajectory initiating and improvement in metabolic parameters. It also enhances his quality of life and his mobility, and there is a potential when he saw us, he was about to return to his traditional schooling system. We continued our multidisciplinary team care at the Metamor, and we also followed up his care with pediatrician. This is his journey at 1 year with Dr. Shower. I'm going to share a bit of the parameters at follow-up. So this is his baseline parameters, 6 months, 2 years, and the last visit he had last week at 30 months with the pediatrician. So if you can see, the HbA1c at baseline was 5.8, was pre-diabetic. It came down to 5.3 at 2 years. And he had high triglyceride, what was 174, came down to 104 at 6 months, and at 2 years it was 31. His iron and ferritin were normal preoperatively, but during the 2-year follow-up, we noticed that his ferritin levels was coming down. So on top of his multivitamin supplementation, he was added on iron tablets. Otherwise, other parameters looks pretty normal. So I'm going to summarize his body weight trend. So he came out with highest body weight with 151.5 kilogram. Just before surgery, his weight went down by 10 kilogram to 141.5. He was put on semaglutide weekly dose then. And after surgery, it was a drastic drop in his weight from 109 at 6 months, 99 at 1 year, and his lowest weight was 95 at 18 months. So when we saw him at 2 years, his weight was start gaining weight to 102, and now he's at 112. The most important thing is here is his comorbidity has resolved. His sleep apnea has resolved. His pre-diabetic is resolved. His hypertriglyceridemia has resolved. He had mild steatosis, but there was no fibrosis during the liver biopsy that we did during intra-op 2 years ago. So he started off with a BMI of 61, and now his recent BMI is 41. And he has improvement of his HbA1c from 5.8 dropped to 5.3. But most importantly, he's able to go to school and he's playing football at his football team. So he did have good quality of life with this weight loss surgery, which I don't think he would have had that with medication or lifestyle intervention alone. He lost about 50 kilograms after surgery within 18 months. So this is his picture before, 6 months after surgery, and at 1 year. So I would like to recommend those who are interested in referring or knowing more about bariatric surgery in adolescent, would like you all to suggest to download our childhood obesity toolkit from the Grow Healthy. There's a section on frequently asked question doctors that may be helpful in knowing about more about metabolic and bariatric surgery in this group. As we can see, there's a lot of challenges and barriers in performing surgery and having this patient going for surgery in general. So one of the major issue is the access to care. So in US, there are total about 108 total comprehensive accredited adolescent bariatric surgery program. In Southern, we have 28, and in Louisiana, we are the only one that actually operates on adolescent. We actually applied for full accreditation this year, so we hope to get that. So the access to care for bariatric surgery is limited, and therefore it can be very difficult to refer a severe obesity child to get the best treatment. Some of the other challenges that we do see is providers' concern. Providers are concerned about the how to refer, who to refer, when to refer, and what is the best age to refer. So there's a lot of concern about the eligibility of going for bariatric surgery. The other concern that we always see is lifestyle counseling is always been preferred as compared to a more aggressive intervention such as surgery or pharmacotherapy. This is because of the nature of the patients, and they are not well versed about what is available for them. But last but not least, the cost. Of course, surgery is much more expensive, but I'm very sure it's more effective and sustainable with other modalities. So I'm not saying surgery is suitable for all patients, but surgery should be given a choice for patients who really needs it, like in patients who have severe obesity with BMI more than 40. So in order to combat all the challenges and barriers, the best is to have best practice guidelines and using the national accreditation standards in treating childhood obesity. Multidisciplinary care model is one of the major things that we have to look into, especially when we deal with childhood obesity. What are the future direction in managing severe obesity in adolescents with bariatric surgery? First, we would like to have more clinical research, looking specifically on cost effectiveness in managing adolescents with severe obesity and looking at their long-term outcomes. Then you can answer what is the optimal age for surgery, what kind of procedure should we choose for what patients. We have more tailor-made treatment approach in these patients. And we should try to get our insurance companies to support bariatric surgery program for adolescents with severe obesity. So ladies and gentlemen, the take-home message here, bariatric surgery is an effective, durable treatment for severe adolescent obesity. It leads to significant weight loss and comorbidity resolution. It improves quality of life and psychosocial well-being. It is safe to be performed in an experienced centers with multidisciplinary team approach. The short-term morbidity is about 2 to 3% with a mortality rate as low as 0.1%. Nutritional deficiencies can be prevented with supplementation and early detection. With that, I would like to thank everyone for your attention.
Thank you, Dr. Zuby, for that wonderful presentation. I think we have a question or two in the chat. So we have one question, and that is, what are the consequences regarding fertility for post-op teens?
Okay, as we know, most patients or teenagers who have severe obesity, they usually have PCOS, which results in menstrual disorder, where they have menstrual abnormalities. So when they lose weight after surgery, they become more fertile. So therefore, we advise these patients to be on contraceptive and not to be pregnant within 12 to 18 months.
Any other questions?
It looks like there's a question in the Q&A. The question is, how many adolescent bariatric surgeries has Pennington/Metamor done?
Can you repeat the question? I can't see the question.
How many adolescent bariatric surgeries has Pennington and Metamor done?
Up to date, we have done about 60. But this was the census until 2024. So Metamor has been established since 2020. So until end of 2024, which about 5 years, 4 years plus, we have about 60 patients. Patients that we have operated on. So our longest follow-up is 4 years plus.
And we have another question from the chat. Do teens have abnormally higher post-op body image problems?
So I foresee yes, because they tend to lose weight much faster. But because they are in an age group where their muscle mass loss are relatively slower as compared to the fat loss, so they do have saggy skin and all that, but it's not so obvious as adult. So, but there is no published study looking at this specifically on psychological aspect of this. So I think it will be good. It will be a good idea to have one.
Dr. Zubi, in relation to that, do you often find some of your adolescent patients requiring any type of plastic surgery procedures afterwards?
So far, we haven't referred anyone yet. The reason could be because we are still very young in this adolescent program at Metamor. But I think if you see long run, I think there will be a potential that they might have to refer.